A very good evening, everyone. Myself, G. Arunagiri from Government Medical College, Thiruvalur, and I'll be hosting this session today. I will heartily welcome our AATRAL staff faculty, Dr. Rajapriya ma'am. We can start the session. Over to you, ma'am.
Thank you. Thank you so much. Shall we start the session? We shall start with the gynae case presentation today. Can you share the PPT?
Yeah, I will share the PPT, ma'am. Is it visible?
Okay.
Yeah.
I'll stop.
Yeah, I will. I've unmuted everyone, ma'am.
Yeah.
It can be an interactive session.
Okay. Yeah. Okay. So again, we are looking at history taking in gynae case. So we are starting with the name, age, residence. We have discussed the importance of all this yesterday. The socioeconomic status, education status, occupation, everything. So what is the importance of age in a gynae case? Can anyone say?
Fibroids are common in reproductive age group, ma'am.
Very good. Fibroids are common in reproductive age group. Then most of the menstrual disorders are common in reproductive age group. Younger kids always present with
older age group.
Yes, younger kids they always present with amenorrhea, that is like primary amenorrhea or it can be secondary amenorrhea. Then younger kids can also present with germ cell tumors very rarely. Then what can younger kids present with? They can present with leukorrhea again. Reproductive age group, most of the diseases are confined to reproductive age group like fibroids, adenomyosis, endometriosis, even malignancies. Yes.
Endometrial carcinoma is more common in old age, above 50.
Yes, yes. I told endometriosis. Yes, infections, STDs more common in reproductive age group. And elderly individual, malignancies are more common. Apart from that, there is something called pelvic organ prolapse, POP. That is also more common in elderly women. Residence, socioeconomic status. How does socioeconomic status matter here? It affects the
Carcinoma cervix is most common in low socioeconomic status.
Yes, very good. Then
Genital tract infection.
genital tract infections, all STDs are more common in lower socioeconomic status. Then malignancies like endometrial carcinoma is more common in upper socioeconomic status. Then education status, that which will help us to counsel the patient and to proceed with the treatment. Occupation, is there any occupation hazards in gynae case? Any occupation hazards you can remember?
Asbestosis, ovarian cancer.
Okay, yes, very good. Then
Excessive weight bearing jobs.
excessive weight gaining job results in pelvic organ prolapse. Also, risk of tuberculosis infections will result in pelvic organ prolapse. Then the patient will present with chief complaints. She can present with anything. Most of the common complaints will be menstrual disorders. What is a normal menstrual cycle? What is a regular menstrual cycle? A regular menstrual cycle is one where the patient gets periods every 21 to 35 days gap, and she gets a periods for about 3 to 5 days, and she soaks at least 1 to 2 pads per day. That is around she loses 50 to 80 ml per cycle. That is a regular menstrual cycle. So what is irregular? Anything apart from that is irregular, either by duration or by frequency or by quantity. That is irregular cycle. Yes, volume. Very good. Then what else the patient can present with? If the patient presents with prolonged bleeding, prolonged cycle, what does it indicate? Can you come to some diagnosis? Oligomenorrhea. Most commonly, not PID, oligomenorrhea. That is, she has got prolonged cycles, but the cycle duration, everything is normal. Prolonged cycles, most common, yes, thyroid disorders can present. Most common is polycystic ovarian syndrome. So what is polycystic ovarian syndrome?
Some hyperestrogenic state.
Yes, very good. Where there is FSH is very high. So FSH is high, LH is double the time of FSH, and the patient presents with hyperandrogenic features like acne, hirsutism, excessive weight gain, all these, and the patient presents with prolonged cycles, that is oligomenorrhea. What are the PCOS presents with? PCOS also presents with subfertility. The infertility term has been replaced by subfertility. So the patient presents with subfertility, and what are the presenting complaints the patient can present with? She can present with intermenstrual bleeding. What are the differential diagnoses for intermenstrual bleeding? Yes, very good. Endometrial polyp, cervical polyp. Patient can rarely present with fibroid. Then endometrial carcinoma, cervical carcinoma more important. Then pre-malignant cervical lesions or infections, STDs. Then patient can present the trauma. Yes, very good. Everything included. Then if the patient presents with postmenopausal bleeding, what are the differential diagnosis?
Endometriosis.
Postmenopausal bleeding, da.
CA cervix,
Very good. CA cervix.
CA endometrium.
CA cervix has a bimodal age distribution. It is more commonly seen between 35 to 45 years of age, and then again another peak is seen after 65 years of age. So the patient can present with CA cervix, very good. Endometrial carcinoma, very good. Endometrial hyperplasia, simple
Senile
hyperplasia.
endometritis.
Very good. Most common is senile vaginitis. That is the most common presentation. Then patient which is started on hormone replacement therapy, that is estrogen therapy, can also present postmenopausal bleeding.
Senile vaginitis.
Very good. Senile vaginitis, senile endometritis.
Senile vaginitis.
Yes, yes. Then what are the presenting complaints the patient can present with? Patient can present with mass descending pervaginum. What does it say? It is a pelvic organ prolapse. It can be either the bladder or it can be the uterus or it can be part of the uterus or complete prosidentia. The patient presents with mass descending pervaginum. Then what are the complaints a patient can present with? Patient can present with just abdomen distension. Just abdomen distension. That can be the main chief complaint. What are the differential diagnosis? What is the first diagnosis you should come to mind?
Fibroids.
No. Abdomen distension, most common presentation is ovarian malignancy. Ovarian malignancies are usually asymptomatic and they usually present with ovarian distension and dyspepsia. These are the presenting features. Then the patient you can elaborate on the presenting illness of the patient. How long the patient has been having these complaints, all the negative histories. Then you'll go on with the menstrual history where you will present the age of menarche. Why is age of menarche important? What situation age of menarche is important? Yes.
Early menarche, late menopause.
In what situation?
CA ovary.
Ovarian cancer.
Ovarian cancer. Why ovarian cancer is related with the early menarche and late menopause?
Regular
Because
ovulation occurs.
yes, with every cycle, the patient has a follicle which is rupturing. So every time there is rupture of the ovarian stroma. So there is high risk of ovarian malignancy. What are the risk factors for ovarian malignancy? What are the risk factors you can say?
Early menarche, late menopause, absent
Very good.
breastfeeding, nulliparity.
Okay. Nulliparity, then obesity, then any other conditions you can say? Any familial conditions you can say? BRCA1, HNPCC, Lynch syndrome, very good. Then what are protective against ovarian malignancy?
Tubectomy.
It is not actually tubectomy, it is
Pregnancy.
It is salpingectomy, that is total removal of the tubes. Then pregnancy, yes, pregnancy is protected.
Lactation.
Lactation amenorrhea, okay. No, actually oral contraceptive pills which are taken for 5 years will give a protective effect against ovarian malignancy for the next 10 years. Oral contraceptive pills, pregnancy, lactation, then salpingectomy. These are protective against ovarian malignancy. Then what is important about age? About the age at menarche? Anything significant? Germ cell tumor. Age at menarche is very important with germ cell tumor. Then about what else you'll ask in menstrual history? About the age at menarche, about her cycle, and in case if she has attained menopause, when she has attained menopause. When is the normal age to attain menopause?
45 to 55.
Our Indian circumference, it is around 45. Okay, 45 to 50 is okay. Anybody who bleeds more than 50 years of age, you should always evaluate. More than 50 years, you should always evaluate for, what are we evaluating for? We are looking for endometrial hyperplasia, even worse situation, endometrial carcinoma. Okay, then obstetrics and marital history. What do you ask in a marital history and obstetric history? The Paris obstetric score. How does parity involved in history? High Paris is related with pelvic organ prolapse, then CA cervix. Low parity, nulliparity is related with endometrial carcinoma. Yes. Yes, very good. Past history. What is the significant past history you collect?
Diabetes, hypertension,
Same. Diabetes, hypertension. Why? There is some metabolic
PCOD.
syndrome. Yes, there is something called metabolic syndrome, where it is related to PCOD. And there is one condition, diabetes, hypertension, and obesity is a triad for endometrial carcinoma. Then corpus cancer syndrome. Very good. Then family history. What will you collect in family history? Look for any relatives who had colorectal cancer, then ovarian malignancy, breast cancer. Very good. We are looking for BRCA1 and BRCA2 gene and HNPCC. Then what is the significant family history here in malignancy? The patient should have 2 first-degree relatives who have been affected with the same or similar related cancers. Or the patient should have 1 in the first-degree relative and 2 in the second-degree relatives. Personal history. What are we asking in the personal history? We are looking for bowel, bladder habits, sleep, appetite, diet, everything. How does bowel and bladder involve here? Patient can present with stress urinary incontinence in case of cystocele, or when there is involvement of, when there is difficulty in passing of urine, it can present with cervical fibroid. Yes, constipation. Constipation is very rare in prolapse, while there can be acute retention of urine. That is common in prolapse. Yes, UTI. Okay. We'll move to the general examination. Build. How is the build important here? Obese individuals again risk of PCOS, again risk of endometrial carcinoma. Why?
Individuals can present with hyperthyroidism.
Sorry, what?
Any thin individuals can present with hyperthyroidism, something.
Yes, yes, yes. How is obesity related with endometrial cancer here? There is peripheral conversion of estrogen. So peripheral estrogen is very high. So that is again risk for endometrial carcinoma. Then BMI, same, similar. Pallor, you look for pallor, ictus, cyanosis, clubbing, lymphadenopathy, same temperature, pulse rate, BP, respiratory rate. Next. Systemic examinations. You'll go to CVS, RS. Why is systemic examination important? We are looking for any metastasis. Shall we move to the next slide? Again, spine. Why are we looking here? Spine. What are we looking for here? Again, we are looking for meds. CVS, RS, same. Then parabdominal examination. In the parabdominal examination, what you will say? It is typical like a surgery case. If it is a swelling, you will describe on inspection. What you will describe on inspection? It is abdomen is distended. That is ascites.
Any encroached veins or any mass.
Very good. Striatum, everything.
Hernial orifices.
Okay. If there is a swelling, you will present the swelling as a swelling is palpable around 5 into 6 centimeter size, which is mobile, non-tender, smooth surface, and yes. Then what else you can say? Most likely originating the suprapubic region can be uterus. Then yes, margin also, well-defined margins. Yes, you will describe this swelling like a surgery case. Then this is about inspection, palpation, then percussion. Nothing much in percussion. Then auscultation, nothing much in auscultation also for us. They will give you a pelvic examination finding. Usually they'll give you a pelvic examination finding. If they're not given a pelvic examination finding, you should come with a differential diagnosis. So shall we start with discussing CA cervix? Okay. So how will you screen CA cervix? That is most important. How will you screen for CA cervix? That is by means of pap smear, Papa-Nicolet smear, where you will look for the entire cervix and you will take a small smear from the transformation zone and you will smear it in a slide and you will put it in a fixative. What does a fixative contain? It is 1:1% of
ethyl alcohol.
Ethanol and ether. So you'll fix it for nearly 15 to 20 minutes and then you look for, what are we looking for? We are looking for squamous and columnar cells. And this is a screening test for CA cervix. Apart from CA cervix, what else can you find in a pap smear? You're looking for abnormal cells. We can say intraepithelial lesions, CIN lesions you can identify. Apart from that, what else can you see in a pap smear? You can look for infections. Yes, very rarely endometrial malignancies can be picked and very rarely ovarian malignancies can be picked. Even sometimes fallopian tube malignancies have been picked. So pap smear is the first screening modality. Then what else you can use?
Co-test.
We can do HPV actually, HPV DNA testing. We can do HPV DNA testing. Similarly, we put a cytobrush inside the endocervix and we rotate it for nearly 360 degrees and we put it in a liquid. Similar like of a pap smear, there is something called liquid-based cytology, LBC. It is better than pap smear, where there is this air fixation techniques problems and all can be avoided. And you can mix it with HPV DNA testing. What is the criteria for screening for pap smear? The women should be at least 21 years of age. Yes, very good. And within 65 years of age. And we should start screening after she resumes sexual activity. Then every 2 years, in case if you are doing only pap smear, every 3 years once if you are doing only pap smear, or we can make it 5 years if you are combining with HPV DNA testing. But the Indian guideline states till 45 years of age, at least a woman should have one screening pap smear in her life. After 45 years, you can screen it every 10 years. Then what else we can do? Pap smear, HPV DNA testing. Then what else we do?
Fluorescence spectroscopy, ma'am.
Sorry?
Fluorescence spectroscopy, ma'am.
Fluorescence spectroscopy. அதுக்கு முன்னாடி வேற ஏதாவது இருக்கா? We can use
Colposcopy.
very good. Colposcopy. அதுக்கு முன்னாடி கூட there is something called via villi. Yeah. Visual inspection after acetic acid and visual inspection after glucose iodine. What are we looking for? In visual inspection after acetic acid, we are looking for aceto-white areas, where a punch biopsy is taken in the aceto-white areas, and we are looking for abnormal cells. Same in via villi, that is visual inspection after glucose iodine, we are looking for mustard yellow color areas. This screening for cervical cancer is very important. This is a very important question. In case wherever they go, they will come to this question. Once you will face this question, then you can proceed with colposcopy. What is colposcopy actually? It is a magnification system where you visualize the entire cervix. Then you look for again under via villi, you look for any abnormal areas. There are several gradings to look for any colposcopic features. Then what else can we do? If there is a growth, what shall we do? Shall we go proceed with pap smear? No, we should
Colposcopy guided biopsy.
Very good. Either colposcopic biopsy or just a biopsy, or even sometimes cone biopsy can be taken to diagnose. So what are we then? Shall we talk about CA again? So what is the stages of CA again? CAN 1, 2, and 3.
Dysplasia, ma'am. Moderate dysplasia and severe dysplasia, ma'am. So mild dysplasia, like we see atypical cell in basal two thirds, ma'am. Like
Okay.
2 we like CAN 1 we lower 1/3, ma'am. Like in
Yes, very good.
2 we see basal two thirds, ma'am.
Okay.
CAN 3 like all the cells are present like more than 2/3.
Upper 1/3. Yes. Very good, very good. CAN 1, that is mild dysplasia involving lower 1/3. CAN 2 is middle 1/3, and CAN 3 is upper 1/3. So what is the causative for cervical cancer?
HPV.
Very good. It is not just HPV, it is persistent high risk oncogenic HPV virus. So what are the numbers you know?
HPV 16
and 18.
Very good. 16 and 18. Apart from that, 6 and 11 is involved with only genital warts. That is a low risk HPV. High risk HPV 16 and 18. So we shall talk about what is a HPV virus. Can you say anything about HPV virus? It is a DNA virus. It is a double stranded circular DNA virus. It's sexually transmitted. There are more than 100 serotypes. And the E6 and E7 oncoproteins of the HPV virus plays a major role. It attacks the RB and the P53 gene, and it modifies and causes a dysregulation of the cell. That is a causative factor. Can you tell anything about the vaccine, HPV vaccine? There are 3 types of vaccine. One is a bivalent vaccine, another is a quadrivalent vaccine, another is a pentavalent, nonavalent vaccine. Bivalent involves only 16 and 18. Yes, very good. Cervarix, everything. You are supposed to say as bivalent, quadrivalent, and nonavalent. The latest is the nonavalent, which involves the 9 types, 16, 18. What are the types it involves? 31, 33, 35, 45, 52, and 58 to 56. I don't know. Yes. So when are we supposed to take the vaccine? Ideally, it is supposed to be recommended in the national guidelines itself. By 11 to 12 years of age, both the boys and the girls can be given. 2 doses can be given. Yes, very good. If the patient has resumed a sexual activity, we can give them 3 doses, 0, 2, and 6 months apart. Yes. What does it protect? Why is it given for boys? What does it protect in boys? It protects against warts, again oropharyngeal cancers, then anal cancers. Very good. How will you treat CIN? What is the treatment for CIN 1? Several grading systems are there. One is CIN, another is Bethesda. So how will you treat CIN 1, stage 1? You just have to repeat the smear at 6 and 12 months. That is 6 months, another at 1 year. If there is regression, you can just watch. If there is persistent, then you must go for HPV DNA testing. If there is HPV DNA testing is positive, then you must go for excision or ablation therapy. If HPV DNA is negative, then you can proceed with follow-up screening. In case of CIN 2 and 3, there is excision or ablation therapy has to be done. Last stages, adenocarcinoma in situ, you'll go for either conization or hysterectomy. So what is the treatment? That is, can you say anything about the ablation procedure? Few points. Most commonly done is yes. Most commonly done procedure is thermoablation followed by cryotherapy. You just have to look few points here and there. The problems, contraindications, side effects with these points, with these procedures. Then we'll move on to LETs. They'll definitely ask about LETs, that is large loop excision of the transformation zone, LLETS. This is the treatment for CIN 2 and 3. It is an outpatient procedure. It is performed under local anesthesia and it is an easy procedure, easy to learn, and there is a specimen available for histopathology. The problem with ablation therapy is you can never obtain any specimen for proceeding for histopathology. The last procedure is cold knife conization. What is this? Excision of a cone-shaped specimen from the cervix with the base as the ectocervix and apex at the endocervical canal. This is conization. What is the complication of conization?
Cervical incompetency.
There is a long term. Immediate complication is severe hemorrhage. Where does the hemorrhage come from? Descending cervical artery. Where does the descending cervical artery come? It comes on the 2 and 10 o'clock position. So there is severe hemorrhage and there is infection and there is a cervical stenosis and finally sometimes incompetence. Yes. So what are the types? What are the types of CA cervix? Not the histological types, just the morphological types. Exophytic, endophytic, ulcerative. Yes. Okay, proceeding with it. Okay. The histological types. Most common is squamous cell carcinoma, then adenocarcinoma, then mixed cell carcinoma, then neuroendocrine tumors. What is the pattern of spread in CA cervix? All the malignancies spread either by direct, lymphatic, or hematogenous. Especially in CA cervix, it is lymphatic. It goes directly to the obturator node. That is very more common in CA cervix. Then what is how do you stage CA cervix? It is a clinical stage. Clinical staging. You should read the figure staging of CA cervix. Yes, very good. You should read the figure staging. Then what else we'll discuss in CA cervix? Okay, the patient has CA cervix stage 1A1. What is 1A1? Can anyone say? It is a microinvasive carcinoma where the lesion depth of the lesion is less than 3 millimeter and the breadth is less than 7 millimeter. If the patient has a stage 1A1, if she's an older individual, what will we do? We'll proceed with simple hysterectomy. What is simple hysterectomy? Where you take only the body of the uterus and the cervix. If the patient has a stage 1A1 and she's a younger woman and she wants to retain her uterus for reproductive function, you will do conization. Yes, very good. If the patient has stage 1A, 2, she's an older woman and she's completed family, what will you do? You will proceed with modified radical hysterectomy and pelvic lymphadenectomy. No, modified radical. Stage 1A, 2 is modified radical. So what is here modified radical means? You will again take the uterus and the cervix and the upper part of the vagina along with the parametrium, not worthings, not worthings. This is not worthings. You will take the uterus, the cervix, then upper part of vagina, the parametrium and the paracellular tissues. Paracervical tissue, paracervical tissue just medial to ureter. This is modified radical. Younger woman who wants to retain her uterus, stage 1A2, again very good, radical trachelectomy with pelvic lymphadenectomy. Why are we not doing pelvic lymphadenectomy in stage 1A1, but we are doing in stage 1A2? Because the incidence of pelvic lymph node involvement is just 1.55% in stage 1A1. That's why we are avoiding lymphadenectomy there. If the patient has beyond that stage 1B1 or stage 2A, then you'll proceed with Werthin cystectomy. That is a type 3 you told. Where you take the uterus, body of the uterus and the cervix, and you take the parametrium, upper part of vagina, and you will mobilize the ureter, and then you remove the entire parametrium and paracervical tissue. That is Werthin's. And you associate with post-operative radiotherapy. The best treatment for CS cervix beyond the stage, that will be chemoradiotherapy. Chemoradiation, both combined. That is the best treatment, combined modality. So what is the chemotherapy you most commonly give? We are giving cisplatin, 40 mg per meter square, very good, with either external radiation or combined with intracavitary radiation. So can you tell me any complications with the radiotherapy?
Anemia, diarrhea, proctitis.
Okay.
Bone marrow suppression.
Ovarian failure, ma'am.
Okay.
Any rectal stricture.
Very good.
Osteonecrosis.
Okay.
Any atrophy of vagina, ma'am.
Very good. Okay, these are complications with radiotherapy. You'll read all that. Then we shall move to how will you surveillance a patient? Post-treatment surveillance. How do you do this? Remember, both in CA cervix and CA endometrium, the follow-up is every 3 months for the first 2 years and every 6 months for the next 3 years. And then yearly, annually. Every 3 months for 2 years and every 6 months for 3 years and every annually. The same is for CA cervix and CA endometrium. So we will move on to CA endometrium. Shall we go? I know malignancy is very boring. But what to do? So what is the patient presents? In CA endometrial carcinoma, the patient usually presents with, mostly the patient presents with postmenopausal bleeding or heavy menstrual bleeding. What is heavy menstrual bleeding? Menorrhagia has been replaced by the term heavy menstrual bleeding, where the patient presents either there is increase in duration or increase in quantity. Both are heavy menstrual bleeding. So what do we do if the patient presents with either heavy menstrual bleeding or with postmenopausal bleeding? Same treatment. You'll first proceed with transvaginal sonogram. What are we looking for? We are looking for the endometrial thickness. In case of postmenopausal women, the endometrial thickness should be less than how many millimeter?
4.
Very good. It should be less than 4 millimeter, and there should be no fluid. Then, if it is more than 4 millimeter, or even if the patient presents with postmenopausal bleeding, we are supposed to be doing a pipple biopsy. It is an office-based biopsy, or we can do a hysteroscopic guided biopsy. Either of it. And we are taking and looking for lesions, pre-malignant lesions or malignant disease of the uterus. So what are the types of hyperplasia you know? Simple, with atypia, without atypia, complex with atypia, without atypia. And the progression to cancer also you should know the percentage. What is the percentage? 1, 3, 8 and 29. What are the risk factors for endometrial hyperplasia? Very good. What are the risk factors? The risk factors for endometrial hyperplasia is Patient has chronic anovulation. That is, patient has irregular cycling, prolonged cycles. Yes. Then PCOS, very good. Tamoxifen therapy, obesity. Then sometimes estrogen secreting tumors. These are risk factors for endometrial hyperplasia. If the patient has come with simple or complex and there is no atypia, what will you do? Simple or complex hyperplasia but with no atypia. You will put them on progesterones. Very good. You can put them on medroxyprogesterone, 10 mg per day, or very good, LNG-IUD. What is LNG-IUD? Levonorgestrel intrauterine devices. How much does it release per day? It releases around 20 micrograms. Very good. 20 micrograms per day it releases. It is equivalent to taking medroxyprogesterone acetate 10 milligrams per day, or even 20 milligrams per day. If the patient has a simple or complex hyperplasia with atypia, what will you do? If the patient is a younger individual, again you can try with LNG-IUD or with Meprate, and you can repeat the sample after 3 to 6 months. If the patient is an older individual, you will proceed with hysterectomy. Yes, surgical laparotomy. Okay. What is the staging endometrial cancer? It's a surgical staging. Surgical laparotomy. That is called staging laparotomy. Can you tell me the steps for staging laparotomy? We make a midline vertical incision. Then, yes, very good. Midline vertical incision. Then peritoneal washings is done and it is collected for any tumor cells. Then we explore the entire pelvis. Then, very good. Simple hysterectomy or extrafacial hysterectomy is performed. Bilateral salpingo-oophorectomy is performed along with it. THBSO, yes, very good. Then pelvic or para-aortic lymphadenectomy will be done. In case advanced stage, we will always remove infracoelicomentectomy along with cytoreductive surgery. This can be combined as a cytoreductive surgery. So what are the types of endometrial cancer, you know? What are the types? Most common is endometrioid. Yes, type 1, type 2, yes, that is there. Type 1 is estrogen dependent, most common in younger individuals or perimenopausal age group. And there's mutation of P10 and KRAS here. While type 2, there is mutation of P53, it is postmenopausal, it is not estrogen dependent. Very good. But what are the other types is endometrioid carcinocarcinoma is more common, followed by serous carcinoma. Then what is the treatment here? Stage 1A, what do you do? Stage 1A, just observation, then proceed. STH-based observation, along with vaginal brachytherapy in case if the grading is 3. Stage 1B, you do external pelvic radiation, vaginal brachytherapy, followed by cytoreductive surgery. That depends upon the patient. What is a successful cytoreductive surgery? When the residual tumor is less than 2 centimeter, that is a successful cytoreductive surgery. Then, what are the drugs commonly given for chemotherapy here? Again, cisplatin, paclitaxel, cyclophosphamide can be given. Sometimes it is combined with progesterone therapy. Younger women's progesterone also is given, either megestrol or medroxyprogesterone acetate. Sometimes even tamoxifen can be given. Okay, shall we go to ovarian malignancy? Is it too fast? I myself feel very fast. What are the risk factors in ovarian malignancy? You all became very mute. What happened? It's boring. Okay, early menarche, late menopause, infertility, then endometriosis, family history of malignancies. Yes, all these are risk factors. How will you screen? Usually the patient presents with abdomen distension or dyspepsia. How will you screen? We are looking for any ovarian tumors, ovarian cyst. So what and all ovarian cyst you can see? Ovarian cyst, most common ovarian cyst presentation is follicular cyst. That is functional cyst. What are the functional cysts you know? Yes, follicular cyst, or it can be a corpus luteal cyst. It can be theta lutein cyst. Very good. It can be inflammatory lesions like tubo-ovarian abscess that is seen in TB. Or it can be neoplastic, either benign, malignant, or even both borderline. And other conditions, you can see a cyst in case of polycystic ovarian syndrome where it is very big, enlarged, very good. Endometriosis, you can find a chocolate cyst, or sometimes you can even find a para-ovarian cyst. Or following infertility treatment, you can find OHSS, hyperstimulated ovaries. These are the most common cysts seen in scans. What is the significance of this? What is the significance of a scan? You can identify what type of cyst it is based on the appearance of the cyst, the wall, thin wall, thick wall, presence of solid areas, calcification, and septations, and along with the presence of ascites. Yes. Do you know any other radiological marker to identify malignancy? There is something called RMI, risk of malignancy index. Okay, there is something called risk of malignancy index, and there is something called ROMA also. Yes. Then you can follow up it with CA125. What is CA125? It's a carbohydrate antigen 125. It is present in most inflammatory lesions and malignancies. It is used for follow-up and for sometimes even the diagnosis of ovarian cancer. What ovarian cancer presents with CA125? Epithelial ovarian tumor presents with CA125. Yes, very good. Epithelial. Germ cell tumor presents with inhibin A and B. No, that is dysgerminoma. Dysgerminoma presents with LDH. Embryonal carcinoma, choriocarcinoma presents with HCG. Endodermal sinus tumor presents with AFP. This you should remember. What are the tumor markers? Which tumor? Okay, if it is a small baby, it is an infant baby. It presents with a mass in the adnexa. What are the differential diagnosis? What will you think? It can be again a functional cyst, or it can be a germ cell tumor. If it is in a prepubertal girl, small child again, it can be again functional cyst, or it can be a germ cell tumor. Most common. Very good. It's adolescent, again functional cyst, germ cell tumor, and very rarely epithelial tumors. Epithelial carcinomas can also come. Puberty age group. What is the most common apart from functional cyst? Ectopic pregnancy. So we are talking about tumor. Erythema, very good. Dermoid cyst, epithelial tumors. Then perimenopausal, epithelial cancers, and functional cysts. Most common is epithelial cancer. Postmenopausal, it is always neoplastic ovarian tumors. 90% of the lesions in the ovary is always malignant. Patient in the postmenopausal stage should not have an ovary that is palpable or that is enlarged or even in the normal size. What is the complication with the ovarian mass? Even it is a functional cyst. If it is less than 5 centimeter, you can just observe the cyst. If it is more than 5 centimeter, there is risk of torsion. Very good. There is risk of rupture, hemorrhage, infection, and development of malignancy. And there is something called pseudomyxoma peritoniae. What is pseudomyxoma peritoniae? Patient presents with mucinous secretions in the peritoneum. That is because of most commonly associated with mucinous cystadenocarcinoma. It can also arise from carcinoma of the appendix and from the colon. Okay, what to do with ovarian malignancy then? How will you diagnose? We saw surgical staging again. What else you want to discuss in ovarian malignancy? You should read about every tumor, and it's usually macroscopic appearance and any microscopic specific cells present that you should read. This may be helpful in your yes, treatment is there. This might be helpful in your Viva session in the afternoon. They might give you a specimen and they can ask you, describe the specimen, what it can be, what is the most likely diagnosis, all that. So shall we discuss something about germ cell tumor? We will discuss the germ cell tumor. Most common is dermoid cyst. It constitutes about 5% of all ovarian malignancies. Then any other points about germ cell tumor? It is very chemosensitive and it's got good prognosis, mostly unilateral. Anything else shall we discuss? Anything else you want to discuss? Shall we discuss?
Fibroids prolapse.
We'll discuss about pelvic organ prolapse. Yes. 1 second. What is the classification pelvic organ prolapse?
POPQ classification.
Very good. You are going random, going to POPQ. Before that, simpler classification.
Based on anterior to 2/3, upper 2/3 and lower 1/3.
Very good.
Posterior upper 1/3 and lower 2/3.
Okay, very good. You can either go with the Schaaf's classification, that is the most common used to classification. Then you can proceed with POPQ. So first you should know what is the supports of uterus. Can you tell me what is the supports of uterus? The upper part of the uterus is not supported by any ligaments. The lower part, the cervix, is supported by means of the uterosacral ligament and the cardinal ligament. Then
Pelvic fascia and paracolpus.
yes, it is held by the pelvic floor muscles, that is levator ani. Then you should know the supports of the vagina. What is the support of the vagina? The upper part, that is level 1, is uterosacral, again cardinal ligament. Level 2 is all by the fascias. Arcus tendinous fascia pelvis, arcus tendinous rectovaginalis, and lower third is by means of perineal membrane, perineal body, and perineal muscles. This is important. Then what is the risk factors for pelvic organ prolapse? Menopause itself, yes, estrogen deficiency, then age, menopause, multiparity, pregnancy, and delivery complications. What are the complications in delivery? Yes, collagen deficiency also. What is the complication delivery you will see here? Prolonged second stage, prolonged bearing down, and operative vaginal deliveries. All these are risk factors. Apart from that, there is increase, yes, very good, increase in intra-abdominal pressure like constipation, smoking, chronic lung disease. All is also risk factors. POPQ and all you know, I think. Then what we want to say? What is the differential? Very important. What is the differential diagnosis for a pelvic organ prolapse? You can always differentiate it with the, yes, inversion. Very good. Inversion of uterus, or endometrial polyps. Cervical or endometrial polyp it can be, or even just elongation of the cervix can be, or very rarely Gardner cyst. This is the differential diagnosis. This you should be able to say. Then if the patient has an ulcer on the most dependent part, most commonly it will be the cervix. What it is called? It is called a decubitus ulcer. The risk of the decubitus ulcer turning malignancy is very high. So we are supposed to reduce, they will ask all this, reduce, retain its position, pack with the pessary, and you can give even small dose estrogen therapy, estrogen creams. Can you tell me anything about the vaginal pessary? Vaginal pessary is usually indicated in old age, where the surgery is contraindicated. Most commonly done is ring pessaries, or sometimes smooth pessaries can be put. Donut and all we are not using nowadays, but most common done is ring pessary. The pessary can be cleaned every day or at least every week, and the patient herself can insert it. Yes, if the pessary has to be changed every 6 months. Additional use of estrogen cream can be given. Then you must know the steps of vaginal hysterectomy and abdominal hysterectomy. Then we'll go to fibroid. What is the risk factors in fibroid? Risk factors.
Early menarche, late menopause.
Early menarche, late menopause is okay. Then any other risk factors? Okay. We just discussed about the last thing, important thing. This important drugs you should read. You should have an idea about the MTP drugs, that is mifepristone, misoprostol. What is the mode of action? I cannot hear any of you. You can just message, I think. All those things. And MTP Act. You should have an idea about the MTP Act. When was it started? What is the guidelines? And when was it reinforced? And latest update. And also you should read about oxytocin They can give you an ampule of oxytocin. They will ask you about oxytocin, duration of action, onset of action, complications. Then methogen, misoprostol, NSAIDs, Lupride, which is a GNH analog. They'll ask you the dosage. Most commonly available is 3.75 mg, or you can also give them as 2 cc or 4 cc subcutaneous doses. Then antagonists, then OCPs, then newer generations like ulipristal. Then you should know about emergency contraceptives. They can ask about USP regimen, or even the levonorgestrel, single dose or 2 dose tablets, 1.5 mg. That also they can ask. Then you should read about the instruments, mostly copper T 380A or 375 multi-load, LNG IUDs, forceps vacuum. In case of forceps and vacuum, what are the criteria for application and how will you will apply? What are the complications? All these 3 things they will ask. Then they can ask about a HSG X-ray, which is a you should say it is a contrast enhanced X-ray. Then if it is a bilateral tubal spilling block is there, they will ask you about the diagnosis. Infertility, what do you want about infertility? Most common infertility, 30% is because of male factor infertility and 30% is female factor, 30% is unexplained infertility. Then female factor infertility, ovarian factor contributes about 30-40%. Then tubal factor contributes about again 30%. Then apart from that, cervical, uterine, all those things, and even immunological factors will be there. Then male factor infertility, I totally forgot. Then unexplained infertility, most commonly seen as unexplained infertility. They'll ask you about the diagnosis of infertility. How will you define the infertility? Now the term has been replaced by subfertility. That is a person who's having a regular unprotected intercourse for 1 year. If the person is if the couple is less than 30 years of age, and if it is more than 30 years of age, it is only for 6 months. You can name them as subfertile couple. And then you can give them a set of investigations, look for where the problem is, and you can try to rectify. The first, most commonly will be female factor. Ovarian factor will be, you have to look for PCOS. Then tubal factor, you look for whether tubes are open. What conditions tubes will be blocked? First one is tuberculosis. Most common is chlamydial infection, Neisseria gonorrhea infection. Yes. Then they'll ask you about the HSG findings. HSG findings in TB. Yes. Very good. Cornwall fibroid, everything. Then what else in infertility? Then you can ask the couple to go for ovulation induction. The treatment part, mostly they will not ask you, either ovulation induction or IUI or in case of IVF. What else in infertility you want? They will not give. Most commonly, they will not give infertility. Infertility is for PG exams. Then important part you should read about is a fetal skull. For the afternoon viva, they will ask about fetal skull and the pelvis, all the diameters and the presentations and mechanism of labor. In case if it is a breech presentation, they gave you infertility. It is usually PG paper. What do they ask you in infertility? The MMC is very level. But infertility is most commonly not given. Even in case infertility is given, they most commonly confine you with the history taking part, examination, how will you diagnose, and they very rarely go to the treatment part. It's a short case. It's terrible. Okay. Okay, so this important things you should discuss and you should be able to say. Then apart from that, we have left out several parts like amenorrhea. Very rarely they'll ask about amenorrhea, secondary amenorrhea, primary amenorrhea. And STDs, you should look for CDC regimens for STDs that you should be able to say. Then vaginal infections, bacterial vaginosis, chlamydial infection. Then sometimes syphilis. They'll ask you to describe the ulcer of syphilis. It was a very short time. This much only I could prepare. So anyway, all the best. In case if you have any doubts, you can contact me. Good luck. Thank you.
Thank you. Thank you so much, ma'am, for this wonderful session. And in spite of those, the network issues, you took your time and cleared everyone's doubt, ma'am. Thank you so much, ma'am. Thank you, everyone who stayed back and listened to our ma'am's session. Thank you so much, guys. See you all with next session. Thank you so much.